Good evening, everyone. I'm
Good
Dr. Dilini
evening.
Vipulaguna. So I'm a acting consultant, community and developmental pediatrician. So today we'll talk about child development and what are the things we are going to assess when we talk about child development, and what is the need to assess child development, and why, as like pediatric trainees, it is important to us. So we will talk about basic concepts of brain development and what is a typical development, as we call it, and what are the ways to assess this development. And at the end, I will talk a little bit about atypical development as well. Now, the brain development is a sequence of several components, so physical, cognitive, communication, and emotional changes. And that helps a helpless infant, a newborn, to become an independent adult. So it's a continuous process that occurs in stages. Now, when we talk about development, we talk about several aspects of development. We call them developmental domains. So, we describe several developmental domains when we talk about brain development. The major components are motor development. So, this includes gross motor as well as fine motor skills. And also, we talk about communication, speech, and language. And in this aspect, we talk about two different things. One is receptive, that is how much a child understands, and expressive, how much a child expresses. And then we talk about social, emotional, and adaptive skills or activities of daily living. Also, it's very important to mention cognitive aspects of the development. So each of these domains interact with each other. So it's a very complex interplay between these domains. There would be a single domain that develops as individual. They are all interconnected, and they help child to get into different stages of development by doing being their complex interactions. Now, the brain development happens in a very complex neurological process. So, this includes the growth of neurons, the migration, making connection between them, and also a process called pruning. So, shedding of unnecessary neurons or connections, and finally, myelination. So, this starts in the intrauterine period by about 4th week, and it progresses throughout the childhood, even into late adulthood. So, early adulthood. So, the graph you see actually depicts how quickly these developmental pathways happen and how quickly the brain makes connections. And as you can see, very importantly, most of these connections are made in a very rapid rate during first year of life or first few years of life, and then they come to actually a plateau stage. So this is very important concept when we talk about developmental pediatrics, because when we talk about atypical development, knowing this neuroscience behind the brain development help us to work with children, especially to implement early interventions. Now, this is a program process. So every child, every person born will have this brain development programmed in their genes and their brains. So it's a constant process. So if you take different children over the globe, whether they are in a low middle income country or a high income country, the developmental pattern is usually a remarkably constant thing, but the rate could vary from child to child. And these skills come at sequential level. So usually there's a pattern that the skills follow, and one goal is usually acquired after another. Sorry. So we call this typical development. Remember, it's typical. We don't usually call this normal development. We call it typical development. Now, typical development is you take a population of children and then you check a particular task, performing that at a particular age, and then you develop this is the average rate for this particular task for this age group. Now, when you have a child, what we always do is we compare that child's acquisition of skills to the average or typically developing, so we call typically developing children. Now, acquisition of a key performance skill is called as a milestone. So the starting to walk, starting to talk their first word. So these are milestones. So we call the acquisition of key skill as a milestone. Now, for each of these milestones, again, there is a rough age where the average child or typically developing child would achieve this, but it's always a range. Remember, there won't be a single age that every child would do it. It's always a range. And there are different milestones where there are certain milestones are very consistent. So like smiling or usually walking is also kind of a consistent one. Whereas crawling is not a consistent milestone. So some children will not crawl, some children will crawl in a very different ways, and because of that, the age of crawling will have a very large variation. Now, again, when we talk about typical development, we talk about a median age. So the rough average age, the half of the population, typically developing population, would achieve this skill. Whereas there would be a limit age we talk about as well. So this, what limit age means is you should, at least by this age, you should have this skill. Otherwise, it is considered as atypical development. Now, this is usually, if you think about standard developmental assessment, is considered as 2 standard deviation from the mean. So, as I said, the brain development is decided by several factors, but because, as I said, it's imprinted, the major factor is genetics, as also there's a factor coming from environment. So the genetic factors will define the fundamental potential, whereas the environmental factors would define the potential, how much this potential would go. So it's very crucial, these interplay of these two factors to determine the final outcome of the child. So for instance, positive experiences during childhood would enhance the development, and insults during the initial crucial period of brain development would have an adverse effect on the brain development. And these two are very important diagrams I want you to remember. First one, both of them are coming from very remarkable articles. I have given references at the end. The first one shows the basic concepts of neuroplasticity. And this is to show when comparing brain development to learning, development is more of an experience expectant process. What do you mean by that? As I said, the brain development is a programmed one. So when you're born, your brain and your genes have programmed that you are going to develop like this. Now, this can vary depending on whatever the insult you have, whatever the environmental factors and some genetic factors. But it's majority of the time, it's programmed and experience expectant. Only a minimal part is experience dependent, whereas learning is lot on the heavy on experience dependent. So you need to learn from experience. That's what it means. So this is what the neural plasticity is all about. The second diagram shows the importance of environment when it's come to the brain development. So when you talk about the developmental paradigm, you talk about proximal and distal environment. So what you mean by that? Your family, the immediate caregivers are very important in the brain development, as well as the distal environment. So what the distal environment means, your physical environment, the health service in the country, the interventions available. So this will show that the genetic factors as well as the environmental factors play a key role in the brain development. So now the genetic have little control over, But what are the environmental factors? Probably you can modify. So it's better to know what are the environmental factors that determine brain development. So antenatally, the infections, the toxins, especially the alcohol, radiation, and the drugs mother take would have adverse effects on brain development. Perinatal period, again, infections, metabolic and endocrine disorders, toxins, trauma. So this trauma could be accidental or non-accidental, and importantly, child maltreatment. So understimulation, maltreatment, domestic violence, they have a huge impact on early brain development because of the toxic stress it creates in the brain. So all these factors you need to remember play a vital role in brain development. Okay. So now we now learned the basic concepts about brain development, how it develops, what are the factors that affect. Now we come to phase where we learn how do we assess development. Now we talk about several key terms when it comes to child development. So one is developmental surveillance, the second one is developmental screening, and third one would be developmental assessment. So these three are actually very different terms which I would like to stress upon when we go through, because you as pediatricians should know what is the difference. So what is developmental surveillance? Now I put the kind of definition here for you to take for your reference and etc., but I will explain it in a different way. Now what developmental surveillance means is you take children who have high risk for developmental impairment or developmental disorder and you follow them up. So for instance, a child with a prematurity or child who had hypoxic ischemic encephalopathy. Now, these children would be followed up in a developmental surveillance program, and they will have a clinic visit where the clinician would elicit the parental concerns and take a developmental history and do a little bit of a developmental assessment to decide what's happening. So, developmental surveillance is happening in Sri Lanka, not uniformly, but at certain extent it is happening in Sri Lanka. So remember, developmental surveillance means taking at-risk babies and following them up to assess their development and to see whether they have any adverse developmental outcomes. Now, what does developmental screening means? Now, developmental screening is a blanket procedure. So, in developed countries, what they do, now they have gone beyond the developmental surveillance process and now they try to catch the children who are even appear to have low risk of developmental impairment. So children who never had any risk factors at birth or who do not appear to have any developmental problems, but you still do a population screening at different age points to catch children who appear to have or who are not having these risk factors but would be having any developmental delay or any risk factors for developmental disorders by doing a blanket screening. Now, we also as a country now have started doing this as pilot project. So it is happening in Gampaha district, Colombo district and Kandy district. So it's called Include program, and public health midwives are using a very crude tool. There's a checklist in child development record, CHDR, and now the population developmental screening is happening in certain districts. So you need to know that this is happening because that is supposed to expand into the whole country. So this is American Academy of Pediatric recommendation. So they say for this is for US, but what did they say is that every child should have a standardized developmental screening at least at 9, 18, and 30-month visits to catch children with developmental disorders early, because early interventions for these children are very cost effective and very beneficial for their future rather than catching them later. And remember, they always also said, American Academy, at 18 months developmental screening, other than the regular developmental assessment or developmental screening tool, you need to use autism specific developmental screening. At 18 months, you should be using autism specific developmental screening. So this is American Academy guideline. So I will show what are the common developmental screening tools which are used all over the world. We are not using all of these tools we mentioned here, but probably we have MCHAT, which is the modified checklist for autism in toddlers, translated and partially validated for Sri Lanka, so which is being used in most of the centers, but all the other questionnaires are not translated or validated for questionnaire for Sri Lanka, even though I know several trainees are being trained under some of these developmental screening tools. So most of these developmental screening tools are parent reports. So, at different ages, the health visitor or the doctor just asks parents to complete a developmental screening, and then you score it and see whether this child is at risk of developmental impairment or a disorder. Some of these ones are actually not parent reports, especially schedule of growing skills. The assessor is supposed to do a very basic developmental assessment, but again a screening test, and then catch the children who are at risk. So this is again for your reference to know some of the names. So PEDS is a common one. Ages and Stages questionnaire is commonly used. Well, it's the one used in UK. MCHAT is the autism specific developmental screening. Schedule of growing skills again used in UK. Denver is used in US. Okay, so we talked about developmental surveillance, we talked about developmental screening. Now, what is the developmental assessment mean? Now, when a child filters from that screening or the surveillance to have a risk of developmental disorder or a developmental impairment, then this child will be referred for a comprehensive assessment. Now, this would include assessing each developmental domain in detail, and it is usually done by a trained professional, not only using that tool, but also using certain observations and certain history points. So these are standard assessments that we use again in Sri Lanka, but not fully validated or translated for Sri Lanka. Now, the commonly used ones are Bailey Scale of Infant and Toddler Development, which is designed for babies up until 3.5 years. So, 16 days to 3.5 years Bailey. And developmental assessment for young children, which is a more freely available, less expensive one. Griffith scales of child development is from 0 to 6 years. Wechsler is again something used in US. So these are some of the examples of standardized developmental assessments. So when a professional or a developmental pediatrician see a child and when they want to do a comprehensive assessment, these are the ones they use. Okay, so why do you need to do a developmental assessment? Because it helps you to diagnose early and intervene early to use that brain's plasticity to have a favorable outcome. And also it helps you to come to certain specific diagnosis, especially if it is genetically, if there's a genetic basis, it helps to counsel the families. And also it is helpful for the families because the family is able to understand what is going on with their child and also to get the appropriate help. And if the child is having normal development, that again helps the carers. Now, if by also doing a developmental assessment, you have the opportunity to show the carer what sort of things that a carer should be doing with the child, the developmentally appropriate play skills. So that will have an opportunity for the caregiver to see, okay, these are the things probably I should be doing with my child. So there are several benefits for doing a developmental assessment in a child when you have a query. So developmental assessment not only includes doing a standard assessment, you first need to take a detailed history, which includes the perinatal history, any maternal health issues. Also, you need to take a detailed developmental history of the child. The CHDR would be a valuable tool because you can go through, because the parents are supposed to mark which age the child has achieved the different developmental milestones. And then you need to take a good social and family history to know whether there's a significant family history. And nowadays, a lot of parents have video recordings of their children. So the looking at these video recordings really help the developmental pediatrician to understand the child in the naturalistic environment. So the child would not behave the same as at home when they are in the clinic. So having a home videos are really beneficial, especially in case of a child who's having a social communication difficulty. And also the observations made at nursery, a child's nursery teacher's report, things like that also is really helpful when you're assessing child for development. Now, the very important thing you need to remember, most of the findings we take during developmental assessment are through observations, because children are very difficult to follow a structured instruction, especially for 40 to 60 minutes. So most of your the information gathering would depend on your observation. So you always need to keep your eyes and ears open to understand what is going on with the child. Now, when you first see a parent who's bringing a child with developmental, some concern about development, or this could be your, case or your developmental history, these are some suggestions that you can use as a general screening questions. So you can ask the parent whether they have a concern about the child's behavior, learning, or the development. And then you can ask whether you have a concern about the child's motor, so how he moves, the arms and legs. And then the communication, how much they talk and how much they understand. And then you need to ask about the play, whether they enjoy with playing and what are the play routines they have. And whether there's any regression. So have the child stop doing whatever he or she has done before. And the social development, whether the child gets along with others and how the child is the learning to do things by themselves. So what we call adaptive behaviors, whether the child can eat, drink, wash, get dressed. So these are probably some general screening questions you can ask when you are taking your developmental history. What are the things you need to look at in the examination? So general examination is very important to do thorough, general and specific examination depending on your findings. So basic general examination points include looking at the head circumference, looking at the dysmorphic features, finding any neurocutaneous manifestations, then doing a thorough neurological assessment and musculoskeletal assessment. So to see whether there's any muscular weakness, any muscular dystrophy, or any sensory impairment like vision or a hearing impairment, and general examination to exclude any underlying general or systemic disorder that could contribute to this developmental disorder. And of course, metabolic suggestions of metabolic disorder, organomegaly, again, the specific dysmorphic features, likewise. Okay, so we did the history taking, we did the examination part. Now, how are we going to assess the exact child development? Now, we are going back to our developmental domains. We talked about cognitive, communication, motor, social, emotional, and adaptive skills. So it's very important to know several things when we talk about developmental assessment. So most of the times as trainees or in a busy clinic, what you get to do is a informal developmental assessment, not a standardized assessment. So it's important to remember, first thing, your observation matters a lot. Second thing, you need to have a specific place and quiet environment for child to have the developmental assessment, free of distractions, and you need to have at least only about 2 or 3 adults in the room, because too many people again will distract the child. Usual order of doing developmental assessment is the way I have mentioned. So usually you start with cognitive skills and then you move on to communication skills, and most of the communication skills are actually happening throughout the assessment. So you need to make sure that you pick up these things throughout the assessment. So for instance, if you are checking gross motor and if the child babbles, you need to remember, okay, the child babbled like this. And then you do motor assessment, and at the same time, again, overall assessment of social, emotional, and adaptive skills. So I will go through each of these developmental domains. I will use some videos and some pictures, but I might not do like, 6 weeks like this, 2 months like this, because I wanted to highlight the most important aspects of developmental milestones that you need to be examining or you need to be assessing in a child. So my list won't be very, well, it is comprehensive, but it is not the complete list. So I would recommend you to visit. There are several good websites if you want to know the age appropriate developmental milestones, because it's very difficult to by heart these ages, because that is not something you're supposed to do, because you can't remember all these things. But usually watching and being with children is the easiest way to remember or get to know these milestones. So if you, there are two websites. One is the CDC website. Second thing is there's something called pathways.org. So these two websites give a lot of huge resources of developmental videos. So by watching these videos, you will get a better understanding of how a child would behave in certain age group and what are the basic milestones you should be looking at. I will be going through each of the domains and some of the age groups, but I won't be telling each and everything for each and every age group. Okay. Now, starting from cognitive, I will mention several important concepts we assess during cognitive assessments. So, one important thing we talk about is object permanence. So, object permanence is the child um, learning to know that the objects in the environment or surrounding him cannot just disappear. They should be there somewhere in the environment. So if a toy falls, okay, it falls onto the floor. Or if somebody hides something, okay, that should be under that cloth. So this is the basic of object permanence. So children will develop this around 8 to 9 months of age. So if you give a child, a 6-month-old child, a toy, and if it falls over to the ground, child will only look at the empty space where it was, without looking at the floor. So you can see this video will show by 9 months child would follow a falling toy. Okay, so I put it again. So child would follow a falling toy. Whereas by 12 months, or this is actually a little bit above 12 months, so by about 12 months, children should be able to find a toy when it is hidden completely. Okay, so this is actually You can see this in cognitive as well as in the fine motor section. So when children are young, they have the regarding, or what we call regarding hand, regarding objects. So regarding hand start at 3 months of age, and if it is present more than 5 months of age, it is abnormal. And when children are on 1 month of age, they start to regard objects. And what happens with cognitive development, they used to habituate, or what we call, they get bored with that object. So they always prefer when a novel object is presented. So first, babies would regard an object when it is presented, and after some time they just get bored with that object, and then they will pay attention to a new object when it is presented. So this is also a very important stage of cognitive development. And then when it comes to drawing, so by older children, we assess cognition by the crude method you do is by drawing a person. So a 3-year-old would usually draw a face and 1 or 2 components of a person, whereas 4-year-old is able to actually make hands and legs. But by 5 years, you will be able to have more details, hair, clothing items, and 2D appearance of face, and the fingers likewise. So this is a very crude but very useful measurement method to assess cognitive development in children. And the other way you do is to assessing their basic concepts like colors and shapes. So because when I see registrars, they always ask the ages. I have put the ages just for your reference. So when the cognitive development happens, this is same for colors and shapes both. What they first do, they are able to either match the color or match the shape when you present something. And then they are able to recognize it when somebody asks, show me red, show me a circle. And then only they develop the ability to name that particular color or the shape. So that sequence is followed when you have the cognitive development. That is the sequence you follow. Okay. Now that was the basic things I wanted to tell you about cognition, because I know when you're concentrating on your short cases, you don't have a lot of time to do assessment. So you need to know few things that you assess in a child. Okay. Now we come to receptive communication. So that is how much a child understands. So receptive communication develops again in different ways. So children first respond to sounds, and then they respond to gestures, they understand gestures, and then they respond to the verbal commands or verbal, first, very basic things like their name, and then the objects or names of other people, and then they start to respond to the instruction. So this is how the development of the receptive communication happens. So you can see to the rattle, child turns head to see where that noise is coming from. So deliberately localizing the source of noise. So when the name is called, child is able to look. So usually by 8 months, children should be responding to their own name. What happens in Sri Lanka, usually parents never call children by their name. So we don't really see this. So what you really need to ask Sri Lankan parent is what you call your child at home, and then use that to call the child. Otherwise, you will take it as atypical development. So if a child is not responding to their given name by 12 months of age, it is a red flag, particularly for autism spectrum disorder. So remember, the limit age for calling name is 12 months. Okay. All right. So then the next part of the receptive communication that you need to remember, that they understand that the objects around them are given different names. Now this development happens first with the real objects. So they learn to know the names of real objects, the life size objects. So a cup, a ball, a spoon, likewise. And then later they start to realize that toys, the miniature objects of real ones, also can be called the same name. And later they learn to identify the pictures in a book in a 2D form. So the two-dimensional form also can be named with the same name. So that is how the recognition of pictures object goes. So children will first recognize real size objects, then the miniature objects, and then only they start to recognize pictures. All right. So the next thing, what you usually can easily ask question is how much understanding they have towards their body parts. So children usually point to their own body parts in about 15 months, and they can point to a doll's body part. Very good. What is this? Yes. Very good. So what's this? No. Very good. What is this? Yes. Very good. So they learn only by 18 months that you can name the same body part in another person or a doll especially. So first they point to their own body parts and then only they point to others' body parts. Now I gave a list of the other kind of milestones because again, this is something frequently asked by me when the children are doing these things. So, for your reference, I put this. So what you need to remember is, so it's very easy to remember things. So two-step commands, usually they develop by 2 years. So give doll a drink. What do you mean by two? There are two main words in there, doll and drink. So give doll a drink. So the two steps, they follow by 2 years. But if you put two instructions together, that's only later development. So that's about 3.5 years only. They will understand two instructions together. And then three instruction is about 4.5 years. And they will understand simple verbs around 2.5 to 2 years. And what is meant by functional understanding is if you ask, show me the one you used to drink water, show me the one you used to write something, and they will be able to show it. So they understand each object has their own function by 2.5 years. And then they learn there are prepositions. So there's up and down, there's in and out. So they learn these things by 2.5 years. And then they learn where things have different sizes. So certain things are big, certain things are small, long, short. So this is by 3.5 years. So 2.5 years, 3.5 years. And then what is negative is if you ask, show me who's not wearing a hat. Show me who's not having shoes. So a negative command in a sentence only understood by around 3 years of age. Okay, so these are the main receptive communication milestones that you should be knowing. Now we come to expressive communication. Again, I put a list for your reference. So, what's that? What's that? Yeah. So children will have different ways of expressing themselves. First, they make small kind of grunting sounds, and then they start cooing, and then they start chuckling and making noises. So first, they start with vowels. So it's like ah, e, o, So vowels, and then they start to imitate what is being said by the adult. So that is where a consonant vowel combination comes. So b, b, a, ba, d, a, da. So consonant and vowel combination comes after the vowels. So that is how they start babbling, and then they start bab, 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 which comes into a single word, baba. So that's how the expressive development happens. So usually children will start talking their first word by 12 months, but the median age is usually 15 months. At least by 18 months, they should be speaking a word. So that's the limit age for single words. So by 2 years, they usually join two words. By 2.5 years, they should be able to join 3 to 4 words. By 3 years, they use questions words in their sentences. So they ask questions, and then they use they use conjunction. So they use two sentences together by 4 years, and by 4.5 years, they will be able to tell a small story with sequence, or they will be able to tell this happened first, this happened next, and this happened after. Or they will come home and tell the mother, well, this is what I saw in the road, or this is what happened in the nursery. So by 4.5 years, they will be able to give a sequence and an explanation. Okay. So now we move on to the fine motor. So we talked about cognitive, we talked about the communication, and now the motor aspect. So this is the usual order of your developmental assessment as well. So main thing when you talk about fine motor assessment is observing the child's hands. So this can start from the time you start your cognitive assessment, because most of the cognitive skills are interrelated with the fine motor skills. So children usually keep their hands open by 6 weeks of age, but if you see constantly fisted hands, that shows that there's some hypertonia going on with the child. So usually they bring their hands to midline by 4 months, and they start to grasp things. So they use thumb and several fingers to grasp things, usually by 5 months, but it can go up to 6 months. And then they start to transfer things. So by 6 months, when they start to transfer things, what you need to remember that they can hold two different objects in their both hands without dropping. So this is a new skill they develop by 6 months, and then they learn to throw things as well, and also to, while holding two objects, they can actually go and look at or try to grasp a third object as well by 9 months of age. And then they also start to take smaller things using their thumb and the index finger. So it starts with thumb oppositionally with all the other fingers, which we call the raking grasp, and then they develop only thumb and index finger use, which is called a neat pincer grasp. So by 12 months, you see that children would usually throw things. So they like to throw and see what will happen to that toy or the brick or whatever the object they have. So parents will come and tell, okay, when they throw things, they will stop giving things to child's hand. Now don't always advise parents not to do this, because that's a part of their developmental stage. Only by casting they learn that you have the ability to throw things. Now, if this is absent by 12 months, it is abnormal. Again, if it is present beyond 18 months, it is abnormal. Usually, we see this in children with autism spectrum disorder as a repetitive behavior when it is persistent beyond 18 months. Okay. So, when we talk about handling a brick, there are several things you need to look at. So, observe this child as well. Now you can see this child uses the thumb and all the other fingers to grasp the brick. Now there are different ways you can describe how a child handles a brick. The first picture you see here is called a whole hand grasp. So you use the whole hand to grasp the brick. Then you develop partial opposition where your thumb is opposite all your fingers, but you still use all your fingers to grasp the brick. Whereas later you develop your index finger. So that is complete opposition. And you mostly use your thumb and index finger to grasp even the bigger objects. So this is how the progression of your palmar grasp goes. Okay. Now, again, another skill you check is how a child would use a book or look at a book. So they would turn several pages at a time by 2.5 years, but would be able to turn a single page by 3 years of age. Now, bricks, you know this, it's very common thing to assess. We use the towers to see how many blocks they use to build the tower. Or then by 3 years, they should be able to imitate a bridge with 3 blocks. And 4 years, they should be able to imitate 3 steps using 6 blocks. Now, pencil skills, again, very easy to remember. I put numbers here. It's like a, kind of a easy way to remember. So they will be usually able to do a horizontal line by 2 to 2.5 years, like number 2. They will be able to do a circle by age of 3, and they will be able to do a cross by age of 4. And these are different graphs that you should observe and describe. You don't need to know everything, even though I put it for your reference. First thing you need to know is probably A, what you call radial cross grasp or a cylindrical grasp. And then number C, which is called digital pronate grasp. And then you need to remember G, which is called static tripod grasp. So that is like what we call immature tripod grasp. And the final mature one is actually called dynamic tripod grasp. So these are the probably 4 things that you need to remember, not all of them. Okay. Now coming to gross motor, again I put different milestones for your reference. But basically what we look at, how the child behaves in supine position, how the baby is in sitting position, the standing, and then walking. So supine, basically whether the head is in midline and whether the foot regard is there. Sitting, you check whether the pull to sit, how they pull to sit, and whether they need support to sit. And when they are sitting, whether they are able to carry a toy and whether they are able to turn around while sitting. In the prone posture, you check how much ground clearance they can have, the face and the chest, how much they can lift it. And with time, they are able to lift their weight to one arm to another. So they are able to handle objects while in the prone position. And finally, from the prone position, they get into crawling, and that's how they start crawling. Now standing, by 6 months, they should be bear some weight in their feet. And by 8 months, they should be fully weight bearing. Then by 9 months, they stand holding on, they pulse, and then by 11 months, they should be standing alone. So first they crawl and then they walk with holding hands, then they walk around furniture, and then only they walk alone. So usually our limit age is 18 months to walk by themselves. So later on, there are different things you need to check. So whether they are able to run, jump, walking tiptoe, running tiptoe, and hopping. So this is basically the older or toddlers, the gross motor milestones that you check. And how much ball skills they have. So whether they are able to kick, throw, or so throwing could be underarm, shoulder level, or overarm. And how confident are they using stairs? Whether they can go upstairs and downstairs, keeping both feet on each step or 1 foot at a step. Or whether they can run upstairs or downstairs. So this is how you check an older child. So like a preschooler when you're assessing gross motor. Okay. Now social emotional, the children, we assess social emotional by assessing how they interact with each other as well as how their play skills. So usually the children will be able to imitate everyday activities and pretend play by 15 months. So if there's no pretend play by 18 months, you should be worried because that is again a risk factor for autism spectrum. Now, children, okay. So usually by 1 year, they will be able to follow gestures. And this is how their play development happens. So usually they first play by themselves, then they kind of are spectators when the others are playing, and they play next to each other by 2 years. And by 3 to 4 years, they start interacting, but they are not very cooperative when playing. But 4+, they would play with each other, taking turns, sharing. So this is how the play progression occurs. Okay. Now, what is a developmental delay? So this is, we basically discuss what are the domains and how do we assess this. So what do we call a delay? Now, when you assess a child using a standardized assessment, if it is below 1.5 standard deviation in that standardized assessment, in a child less than 5 years of age, that's where you call it a developmental delay. Now, it could be global or it could be isolated. So, to call it a global developmental delay, a child should have a delay in 2 or more of the main developmental domains. Now, significant delay is when the norm reference testing, when you compare with it, if the child is below 2 standard deviations, that is why you call it a significant delay. Now, developmental delay is reserved for children less than 5 years, which is a very important thing you need to remember. So, referring back to DSM-5 criteria, so any child above 5 years, you consider them either having a learning disability or intellectual disability depending on their presentation. So, only children less than 5 years, you talk about developmental delay. But what is a developmental disorder or impairment? Now, delay suggests that you have a tendency to catch up. So, delay is only used for children who has possibility of catching up. But if you see a child who has a risk of developing a developmental disorder, these children would have early developmental period, they will show abnormal signs of development and they will persist usually throughout the lifetime, and they might not catch up to the typical development even with the interventions. So these are the children with developmental disorders, so like autism spectrum, cerebral palsy, or muscular dystrophy. So these things would be developmental disorders. Now, how common are any developmental problems? The global developmental delay could be around 1 to 3% of the population, but isolated developmental delay is way common than that. Okay, so how would you come across with these children? So either from your developmental screening or surveillance, or parent would have a worry and bring them directly to you, or the children who are attending a nursery or a childcare setting would be noticed by the professionals in that setting, and then they do a referral to you, or in an opportunistic health contact, you might detect that this child is having a developmental problem. So if the child is having a developmental problem, what do? You do a detailed evaluation of development history examination and make sure your vision and hearing are assessed, particularly if the child is having a cognitive fine motor delay that could be due to underlying visual problem. Again, the communication, speech and language delay could be due to a hearing impairment. So If there is a suggestive etiology, you need to do investigations accordingly. But if there's no clue of etiology, what is the etiology? The first line investigation, this is the RCPCH guidance, they suggest doing genetic testing. So genetic testing could vary, but first they usually ask to do a karyotyping, standard karyotyping, and depending on the individual findings, you can go for second line investigation, including a detailed metabolic screening. So what are the pointers for this underlying disorder? A regression, associated seizures or neurological impairment, any sensory or cognitive decline. Also on examination, you have either neuromuscular disorder features, features of any metabolic disorder, etc. Okay. So when these children present to us, what would we do? We present, we concentrate on early specific interventions. They are always family centered and goal directed, and they happen in enriched home environment. We only guide parents, we give them goals, and then we continue the cycle of giving the goals, executing interventions, assessing outcomes, and continue this for the lifetime. So we always have smart goals to guide us, and we always do these interventions depending on the family requirement. So they are family centered. Okay, so these were the basic references I had. Thank you for listening.